customary. We are going to start from the first beginning of what we call the psych, and then we're going to talk first of all about nurse-client relationship. We'll talk about the phases of, clients or nurse-client interaction, and then we'll also talk about therapeutic communication. We'll talk about we will talk about what we call defense mechanism, and then we will, the various forms of admission, specifically voluntary, involuntary admissions, and what we need to know. Okay, then from there we'll try our hands on what we call questions to assess our understanding of some of the things that we'll discuss for today. So possibly in the next 2 hours or so, those are some of the things we'll be discussing. Afterwards, if we have time, we'll move to different things. And we'll now go into conditions, anxiety, we'll go into schizophrenia, and then personality disorders. We'll talk about them, and then we'll see where we can end with it. So those are some of the things that is expected of us from this very topic. So the nurse-client relationship, as we all know, that there are certain principles that before you interact with, especially a mental client, okay, you cannot just communicate with a mental client like how you communicate with a client who has just come with a surgical problem, or is that just a medical problem and you have to just attend to the person. You need to set certain boundaries. You need to be firm on certain things, how you communicate with your client, certain answers you provide to the client. You have to be very careful when you are interacting with people with mental issues. And so that is why we need to understand the principles regarding the nurse and the client relationship. And so the first thing that we need to understand is that before you you interact with someone with a mental issue, okay, or some of the things, principle you need to put in place when it comes to your interaction or your relationship with the mental health clients is to make sure that you are genuine. So genuineness, respect, showing empathy, understanding are some of the important things that develops, a therapeutic nurse-client relationship. So that means that when you want to interact with a client, okay, either a mental health client or just any client at all, you need to make sure that you are very genuine, and then you respect the clients. You don't just have to talk to the clients anyhow. The way you respond to them is very important. So you need to be genuine, you need to be respectful, and then empathetic enough as well to when interacting with your clients. Then the nurse should also be cared for the client should be cared for in a very holistic manner. We know that when it comes to mental health people and we are caring for them, we need different disciplines in terms of the various disciplines to come on board. Okay, you need family in place, all the people who are very helpful in terms of caring for the clients. You need to bring them on board. So the client has to be taken care of holistically, both the physical need, the spiritual need, emotional need of the clients. Everything has to be cared for when you are establishing the relationship with your clients. Then the nurse should also consider the culture and the spiritual beliefs, values in assessing client response to the nurse client relationship and the client's adaptation to stresses. So of course, when you are caring for clients, you need to consider, you need to consider their religious needs, their beliefs in terms of, their religious beliefs. If you are taking care of a Muslim or you are taking care of a Christian, a Jewish or whoever you are taking care of, you need to understand the religious belief of the individual. So let's say you are caring for a Muslim and then the person dies, you should be able to know how to handle the dead body, and then some of the things that relates with culture, relates with spiritual beliefs of the client. You need to put all those things into consideration, and you must respect their cultural values and then religious beliefs as well. Then you have to set boundaries, especially when it comes to mental health clients. You need to set boundaries, especially those with personality disorders, those who have the paranoia, or those who are paranoid, those who are antisocial people, especially the antisocials. You need to set boundaries and you need to be firm on the boundaries. Okay. If the patient comes to you that at 11 a.m. they want a phone to make calls, and you know that the principles or the rules regarding the use of mobile phones are that after 10 p.m., you cannot make use of a mobile phone. No matter how the client describes the situation to you, you need to be firm on that rules regarding, the board and how to use mobile phones. If you joke with them, they can play, mind with you to the extent that you might break that rules. So you need to be very firm, and then you set boundaries. You don't, you have to set boundaries, and then you have to also be firm on your boundaries. Know where to go, especially mental health people. Setting limits is very, very important. Okay. Then we also have to be honest and then open communication. So we always say that when you are caring for mental health people, it is not good to be providing them with just be open, okay, especially when we get to the therapeutic communications, words you have to use and then what words you don't need to use. So you have to open up the communication. Sometimes you have to let the patient choose the topic they want to discuss, and then you now have to go through with them. Okay, so you have to be honest when you are discussing with them. You don't have to lie, and you don't need to be, promising them unnecessarily. Okay, so if the thing is one, just say one. Don't say it is two when you know that the thing is very one. Okay, so you need to be honest and then open in terms of communication, and so that they will, you develop that trusting relationship with your clients. Then the nurse should also use therapeutic communication techniques. We'll go through the therapeutic communication techniques, words that we can use or words we shouldn't use when we are communicating with our clients. Especially, we know that in mental health, we don't use why, okay? We don't make statements like why this, okay? Why statements are not allowed to be used in mental health cases or when you are communicating with your mental health clients. Why, making a statement using why is not allowed. So you need to use what we call good therapeutic communication techniques. Okay, restating, rephrasing, and then active listening to your clients, maintaining what we call eye contact and all those things is very important. Then you need to also maintain confidentiality. Okay, especially clients who come in voluntarily for what we call admission. Even involuntary admission. It's not anybody at all that you can release clients' information to. So you need to maintain what we call confidentiality when it comes to clients' information. You need to only share information about clients to people who are in direct care with the client. Okay, if the person is not in direct care with the client, you don't need to share client information with that very client. So you have to limit discussion of the clients to the interprofessional healthcare team as well. Then the goal of the nurse-client relationship is also to assist, to develop what we call problem-solving abilities and then coping mechanism. So the interaction you develop with your client should be in such a way that it will be helpful in solving the client's problem and then developing coping mechanism. People who have anxiety or who are anxious and then they cannot deal with stresses or stress. Your relationship with the client should be in such a way that it will help the client to be able to cope with those difficulties that the client is not able to cope with. So that should be the focus of what we call the nurse-client relationship. Then the nurse needs to also consider the cultural, I think I've talked about that, the cultural, the religious, and the spiritual practice of the clients. And whether these practices may give the client hope, comfort, and then support whilst healing. So you need to bring everything when caring for the clients. Okay, you need to maintain that respect, you need to respect the client in all aspects, both religious, culture, and all things. Okay. Then we now go into the phases of the therapeutic nurse relationship. So we have three phases. We have the three or four. We have pre-interaction, we have the orientation, we have working phase, and then the termination phase. So there are about four phases when it comes to the nurse and the client's relationship in terms of the phases. So before the client appears, okay, you might have some information about the client. So the pre-interaction phase, it begins even before the client. I mean, before your first contact with your clients. That is when the pre-interaction phase begins. So it begins before the nurse first contact with the clients. It also helps to develop appropriate physical and then interpersonal environment. So the seating, the lighting to promote comfort and everything at where you are going to interact with your client. So the pre-interaction phase is like the setup of your environment, how you are going to prepare to welcome your client in. That is the pre-interaction phase. So before the client comes in, how well have you prepared for your clients before you even, start interacting with the client? So it has to do with the arrangements, around you, the lighting, the seating, and everything. How you can, provide comfort for your client. Then it also helps you to anticipate, potential client issues, prepares for the client's, interaction, determines how to initially approach your clients. And then the nurse also should identify personal preconceived ideas, okay, stereotypes or biases and values that may affect the relationship with your client. So at this point, you the nurse, you need to, assess yourself to see as to whether you have some preconceived mindset about, mental health clients and how you wouldn't make those beliefs to affect your interaction with the client. Okay. And so when you are coming to interact with them, you don't need to be biased. You don't also have to, have some preconceived mindset about them in such a way that your interaction with them will be affected based on your beliefs. So you have to put everything aside and approach the client as the client comes in. So that is a pre-interaction phase. So that is before you even meet the client. What are some of the things that you have put in place before the client comes in? And what are some of the beliefs that you already have that may affect your clients in terms of your client's interaction? That becomes the pre-interaction phase. Then we have the orientation or introductory phase. Now, the orientation or the introductory phase is where acceptance, rapport, trust, and then boundaries are established. So at that point, you have met your clients. So that is where you are going to introduce yourself to your clients, set the rules to the clients that this facility, we don't do this, we don't do this, we don't do this. You need to set those boundaries there. And that is done at the orientation phase. Okay, just like we know what orientation is. You are introducing yourself to the client, you are introducing the facility to the client or the unit to the client. And then what the client needs to avoid when it comes to, your interaction. And then the boundaries you need to set. That is where that part also comes in. You have to introduce yourself to the client by using your first name and the last name. And then the designation, just like I said, where the unit in which you are, you need to introduce the unit yourself as well, using your first and your last name to the client. Then you identify the purpose and the time frame of the relationship. So that is where establish a contract. Okay. So how long is your interaction with the client going to last? Okay. So that is where you need to establish that relationship. And then you also have to let the client know the purpose of the interaction. That is your orientation phase. You identify client strengths and needs that you need to work on it, and then you start gathering data that will help you to assess clients and then diagnose clients. And then termination and the separation of the relationships are discussed in anticipation of the time limited nature of the relationship. So at this point, we might start talking about how the relationship is going to last for, and then at what point you are going to terminate what we call the relationship. Then the last phase, the third phase is your working phase with the client. Okay. So at this point, you are now going to solve the client's problem. Okay. That is the working phase. You have identified that the client probably has let's use eating disorders, okay, like bulimia nervosa or anorexia nervosa, and then you are caring for the client. You have to identify the client problem. It is at this point that you need to, implement whatever you need to implement to help the client, okay? So if it's about certain limit in terms of the amount of food the client will be eating, if it's about letting someone watch the client in terms of the food, the amount of food client is consuming, this is the time that you are going to implement those interventions. So the working phase, you need to, that is exploring, focusing on, and then evaluating the client's concern and problems. An attitude of acceptance and active listening assists with what we call the clients to explore, to express thoughts and feelings. You actively solve the client's problem. Okay, so actively problems solves with the client. So at this point, you solve the client's problem. That is the working phase. It uses interpersonal strategies to also help the clients identify effective coping strategies. And then we encourage self-direction and then self-management whenever possible to promote health and wellness. So the working phase is where you actually solve the client's problem. Then the last phase is where you, terminate the clients in terms of the separation, with the relationship with your clients. So at this point, you might have to refer the client to the community resources that are available, so that the community resource will also take care from there. Okay, and then everything. So you prepare the client for termination and separation with initial contact. Remember that we said that at the introductory phase or at the orientation phase, that is where you need to introduce the client to how long the interaction is going to last for. And so you need to inculcate what we call the termination phase, okay, or you need to talk about the termination phase during the orientation phase. So the client will have an idea on how long the relationship is going to last for. Then you have to evaluate the progress and achievement of goals as to whether the problem the client brought, you've been able to assist the client to achieve them. That is where you need to evaluate. Just like when you join a care plan and then you are now evaluating your care plan to see as to whether your goal has been achieved. So the same thing applies to the termination phase. You need to evaluate, the progress and achievement of the set goals. Then you identify responses related to the, termination and separation, whether there's any form of anger, as to whether when you inform the client about, or at the time of termination, is there any kind of, responses from the client that is not good, like anger, distancing from the relationship, or return of symptoms and dependency. And so there are some people that after you have had that relationship or interaction with the client now tends to depend on you for everything. Okay, so it makes it very difficult for you to now terminate what we call the care or the relationship. Then you now have to encourage the client to also express feelings about termination and then identify the client's strengths and then anticipate the need for follow-up care. And then the last thing would be to refer the client to the community resources and then other support systems within the community, so that when the client gets to the community, the clients can now be attended to by those support systems within the community. So that is with the various phases of what we call the nurse-client relationship. Okay. Then we now move into our therapeutic communication. Okay. Which words can we use when we are interacting with our clients? How should we use it when we are interacting with our clients? Okay. So therapeutic communication is one of the important things when it comes to the English. You should be able to know how to choose your answers, which responses, how they frame the statement. When we get into the questions, we'll get to understand how those questions are framed and the statements are also used. So the therapeutic communication process, we know that when it comes to communication, we either have verbal communication or non-verbal. Okay, so when when you are communicating with someone, you either use, gestures. Okay, those are, expressions. Okay, so gestures, expressions, not necessarily you opening up, your mouth and talking. Then you, verbal communication is also there. So either of them, if you are using it to interact with your clients, you should know how you should use them, and then which words you should also be using. Then successful communication also includes appropriateness, should be efficiency, flexibility, and then you have to get feedback from your client. Okay, so when you are talking with a client, you need to get a feedback after everything so that you get to understand whether the client has understood whatever you discuss with them. Then you need to also watch out, is there any form of anxiety or anything that could cause fear? Or, anxiety in the nurse or the client can affect communication or can impede communication. So you have to make sure that the environment in which you are even, going to talk with the clients, okay, it has to be, free from any form of, distractions, okay, and then a calm environment. And so you need to assess for any form of anxiety, either with regards to you, the nurse, or the client, because if any of you is anxious, then the communication will be affected. Then communication need to also be goal directed or goal oriented. Okay, in a professional framework, we know that when it comes to communicating with your clients, it has to have a certain goal directed. So you cannot just go to a client and then start talking to the client. You should be able to know what that communication you're going to have with the clients, what outcome are you looking at for? Okay. And then you should also know what you are going to talk to or you're going to talk about with your clients. You just don't go and start talking about anything that is not related with the client's problem. So it should be something that is directed towards the clients and then will help the client to achieve their goals. So these are what we call the techniques. These are therapeutic communication techniques. We'll talk about the non-therapeutic ones. So the therapeutic techniques, we have active listening, we have broad opening, we have clarifying, we have exploring, focusing, informing, offering self for help or to help, and then we have to also open-ended questions. Okay, so we'll go through them each one after the other, and then we get to know what each of them means. But when it comes to active listening, it says that carefully noting what the client is saying and observing the client for non-verbal behaviors. So when you are communicating with your client, you need to have active listening, okay, so that you can take note of whatever the client is saying, and then you can also observe for any form of non-verbal behaviors, okay. So client is talking to you and then you have turned your face to a different direction, okay. There has to be that form of active listening when you are communicating with your client so that you can take note of everything the client is telling you. Then there's also what we call broad opinions. So you encourage the client to select the topic for discussion. So you don't select the topic for the client, okay? So let's say you have seen that maybe there is an issue you need to talk. Let's say activities of daily living for the clients is a problem. So when you go to the client, don't go and select the topic that let's talk about this. Let the client, so maybe you can give the clients several of the topics or problems you have identified with the client. Then you allow the client to choose the topic that you should discuss. So that is what broad opinions talks about. So you encourage the client to select topics for what we call discussion. Then you need to clarify. So that means that providing a means for making the message clearer, okay, when you are communicating with your client. The message must be very clear, as if there is any form of words you are using and that the client doesn't understand. You need to break those words down so clients can understand them. You have to correcting any form of misunderstanding and then promoting mutual understanding with your client. So if you make any statement and the client doesn't understand, you need to come to the level of the client so that the client will understand whatever information you are sharing with them. Then you have to exploring, okay, examining ideas, important ideas, experience, and then a relationship more fully. So you need to explore other areas, okay? So whether client has experience about whatever you are discussing about, then focusing. So the communication must also be directed towards like we said, it must be goal oriented. So that directing the conversation on the topic being discussed. So if let's say you are talking about activities of daily living, you have to make sure that you stay on your activities of daily living that you are discussing with the client, or you are talking about suicidal ideations with your clients. You have to stay with the suicidal ideations. If it is about suicidal ideation you are discussing with your client, you don't move from there to a different topic. Okay, so you need to finish with whatever, you exhaust everything about the topic we are discussing. You don't bring in other topics that wasn't chosen during the the broad opinion or whatever you decided to discuss on. You stick to that. So that is what focusing means. And then giving information to the client, that is also about informing. So is it about what we call is it about you are discussing on suicidal ideations? You give the client some of the things that will help the client to know that these things are some of the things that means that I'm likely going to have, suicidal thoughts. So you should be able to give clients information about whatever you are discussing. So you have to also have in-depth knowledge on whatever you are going to discuss. Then you also have to offer yourself for help. So include staying with the clients, talking to the client, and then offering to help the client. Okay, it is very important with regards to what we call them clients therapeutic communication. Okay, you need to always be available for the client. Okay, when the client needs you most, and then open-ended questions. Okay, so we don't use yes and no, or we don't ask yes and no questions when you are interacting with your client. You have to use open-ended questions, not yes and no. So encouraging conversations, because this question requires more than one word answer. So we don't like ask questions that demand yes or no when we are interacting with what we call our mental health clients. So your questions must be something that will let the client talk more. So if you listen to Maki will say that if you have an option that will let the client talk more, go for that option. Okay, when it comes to mental health. So we are always looking at like statements that will open up for the client to talk more, not something, have you eaten? The client say yes, no. So you have to make sure that your statement, you are framing it in such a way that it will allow the client to talk more. Okay. Then we have rephrasing or paraphrasing, sorry. Paraphrasing, that is using, restating in different words that the client said. So clients made a statement or client said something. Then you rephrase what the client said again. Okay, using different wordings. That is what we call rephrasing. We get the questions and we know how to use our rephrasing, and then all the things that we are talking about. We get questions how they ask the questions here. Then reflecting as well. It's also another important technique that we have to employ when we are communicating with our clients. So directing the client's question or statement back to the client for consideration. So client says something, you need to direct, the statement back to the client, okay, for consideration. So that client would like to talk more about it again, so that you can now establish what the problem is and then we help the client out. Then we have restating. So repeating what the client has said and directing the statement back to the client to provide the client opportunity to agree or disagree or to clarify the message further. So just like I said, you need to allow the client to express themselves. So client says something, then you restate that thing again so that you and the client will agree or disagree, or the client will agree, disagree with whatever the client said, as to whether that is exactly what the client said. Okay. Or maybe the information needs to be clear. So you restate it again so that clients will understand that, okay, this is what you meant to say. And then silence. So allowing time for formulating thoughts. Okay. So when you are talking with them or you are discussing something with the people with mental health issues, you need to allow some form of silence where the clients will now sit down and then formulate thoughts or ideas on how to go about the situation. So silence is also another important thing that might be employed when you are interacting. The rest, summarizing everything that has been said. So stating briefly what was discussed during the conversation is also another important thing. And then validating the information. So verifying that both the nurse and the client are interpreting the topic or message in the same way. So you need to make sure that after everything you have discussed with your client, is it actually what you agreed on? Okay, so that you know that, okay, this and this and this are what we discussed, and this are what we agreed on. Okay, so that you all be on the same page or on the same, you all be on the same page. Yeah. So these are the therapeutic techniques that we need to employ when we are communicating with our clients. So these are therapeutic communication techniques. We are now coming to talk about the non-therapeutic communication techniques and then how we should avoid those ones too when we are interacting with our clients. I know that for that one, everybody knows that when we are, interacting with clients, we don't advise. Okay. So it says that avoid giving advice, avoid using why questions or why statements, and then disapproving, disagreeing with your clients and all that. Yes, Mr. Kabir, your hand is up.
Hello.
Yeah, Mr. Kabir.
Please, regarding the usage of the open and then the close ended question, there seem to be an exception, especially when you are dealing with a patient with a suicidal ideation. That you can use a close ended question.
Okay.
Like I ask the client whether he or she is having
suicidal thoughts.
Yes, suicidal thoughts.
Okay.
I think, that's the only exception.
Where you can use the close-ended question.
Yeah.
Okay, thank you. Thank you for the input. So, Mr. Kabir added up that, there are instances where you can use a close-ended question. And that is only when you think that someone is having suicidal ideation. So that you just ask the person, are you having suicidal thoughts? Okay, or suicidal ideations? And that will be a yes or no, statement. Or are you thinking about harming yourself? Okay, those statements. So that one will demand yes, no statement from the client. Apart from that, you always have to use an open-ended question to allow the client to express themselves more. So now let's look at the non-therapeutic techniques. Okay, some of the things that we should be avoiding. Okay, when we are communicating with our mental health clients. Okay, and so you need to always avoid them. And so the first thing is approval. Okay, so approval means that implying that the client is thinking or doing the right thing and is not thinking or doing the what is wrong. Okay, so it's like always accepting what the client is saying, or whatever the client says, you disapprove it, or you just say no. This is not what's supposed to be done. Okay, so you have to avoid approval. That is thinking that what the client is doing is always wrong or is right. So this may direct the client to focus on thinking or behavior that pleases the nurse. Okay? So if the client comes to you and you know that what the client is doing is not really right, okay, you have to open up to the client and then let the client knows that it is right. Don't always say that, oh, okay, whatever you are doing is correct, continue, correct, continue. When you do that, I mean, the client will develop some form of relationship where the client will always think that, let me do things to please you the next. So approvals should be avoided when you are communicating with your clients. Then asking excessive questions, I mean, unnecessary questions, okay? So that's why you need to stay on the topic you are discussing with your clients. You don't need to bring in other things that are not needed when you are communicating with your clients. So demanding information from the clients without respect for the client's willingness or readiness to respond. So when you realize that you are talking to a client and the client is not ready to share with you, you don't have to force the client and continue talking. Okay. If you realize that the client is not ready to respond to you, you have to cut it off. Okay. Don't continuously be asking the question when you know that client is not responding to you. Then changing the subject, of course, just like I said, whatever you decided to discuss on, you need to stay on that. So avoid addressing the client thoughts, feelings, or concern, implying that the client statement is unimportant. Okay, so you need to stay on the topic you are discussing so that you avoid changing what we call, the topic on board that you are talking about. Then the close-ended questions that ask for specific information, such as yes or no answers. It inhibits what we call communication. Okay, so with the exception of what Mr. Kabiri just said, apart from that, when you are communicating with your clients, you need to use statements that will let the clients bring more issues out or will let the client talk more. Okay, so don't use or don't ask questions that will just demand for yes, no, yes, no. When you do that, you are not using good therapeutic communication techniques. Then disagreeing with your client, so opposing the client thinking or opinions, implying that the client is wrong. Okay, so don't disagree, just listen to the client, discuss with the client what the issues are so that you all arrive at the solution. So don't always be disagreeing with what you call your client or disagreeing. And then disapprovals are also not allowed. So indicating a negative value judgment about the client's behavior or thoughts. So let's say client is behaving in a certain way, and then you are disapproving that client's behavior. You need to accept the client, and then you talk about what the issues are. Then false reassurance to the client. So when the issues, you know that this thing cannot be solved, let the client knows that it cannot be solved. Don't go ahead and then be giving some false reassurance to the client. So false reassurance means that assuming that the client cannot think for themselves, which inhibits problem solving and then foster dependency. So don't always think like the client cannot make decisions for themselves. And so for that matter, you are always going to, be there, or you're always going to do the thing for the client. When you do that, it's going to make the client be dependent. Okay, clients will always depend on you. So false assurance should be avoided when you are communicating with your clients, or when at a point when you are establishing your relationship with your clients. You need to avoid false reassurances and then minimizing the client's feeling. Okay, so whatever the client says, you say stop. Okay, or client is saying something, then you are suppressing the client's feeling. So making a statement that implies that the client feelings are unimportant. So we don't have to minimize the client. Maybe the client has said something, then you say that, oh, what you are saying, you shouldn't have said it, or stop what you are talking about. When you do that, it means that you are suppressing the client's feeling. Okay. Remember, we said that the mental health, we always have to allow the client to express themselves. Let the client talk, okay, or let the client continue to talk. Then placing the client's feeling on hold, okay, avoiding addressing the client thoughts, feelings, or concerns, making a statement that places the client responsibility of addressing the client thoughts, feelings, or concern, elsewhere or another person. So let's say client has asked you a question, okay, and you say that I am waiting for the healthcare provider to come before the thing will be addressed or before the client's question will be answered. Now, when you do that, that is a transfer of, responsibility, something you can do or something you can answer. You need to answer that, okay? It's only when it is only the healthcare provider that can do that. That is when probably you say that, okay, let's wait for the client, the healthcare provider to come. Even with that, you have to do everything, within your scope of practice that you can do to help the client to solve or to answer the client's, questions or problems. So you don't have to, make statements or things that put the client's feelings on hold, and then value judgments, okay, making comments that address the client's morals, okay. This can make the client feel angry or guilty, or as thoughts they are not being supported. So you don't need to, what you think is right, the client might think different way. So don't always, be making comments that address the client's, morals and those things. So as I said, what you think is right, maybe to me it is wrong, or what to you is wrong might be right to me. So don't always try to tackle that aspect of, my moral upbringings and those kind of things. Okay, when you are dealing with people with mental health issues, might make the clients become angry or feel guilty and those things. And the last thing is that avoid the use of why questions. So why questions should always be avoided. So it may cause the client to feel defensive because many times the client does not know the reason. So why should be avoided? This type of questions are often, it implies criticisms, like we are criticizing the client when you make statements using why. Why did you do this? Why this? Why that? Okay. So when it comes to therapeutic communication, I believe everybody here, whenever we meet why question, just take that one out first. Why? Take it out before you proceed and check on the other statement to see which one it should be avoided or not. So those are the various therapeutic communication and the non-therapeutic communication techniques that we should know for the purpose of our exam, and then how we should also use them in our questions or in our statements and how to apply them. Now we'll get to the question aspect. It will help us to get a better understanding of whatever I've said so far. And then you see how the questions will also be framed for us to get a better understanding. Now, if you have an input you want to make, or you have something you want to say, you can bring it up, whether question and input on whatever I've said. You can also bring it up before we go into our defense mechanisms. Okay, so the defense mechanisms, we go through them one after the other. We look at examples to each of them. So when we take denial, we look at example with regards to denial. We take maybe sublimation. We take all the the defense mechanisms that are there so that we discuss on them. So we know that when it comes to defense mechanisms, okay, they are employed.
Flamingo.
Yeah, hello, madam.
Sorry. Please, I hope this is even though it's you are treating it under mental health, it's like the general thing for all the cases, so all therapeutic
Yes, sure.
communications,
Yes, please.
or it differs in other conditions.
So it applies to other, okay. Just that therapeutic communication itself falls under psych. Okay. But whatever is being said, you can apply it in, what we call them, medical or research, you can apply it there.
Okay, please.
So on defense mechanism, I was saying that a client mostly employs it, okay, as a form of coping mechanisms. So especially when they go into fear, they are in an anxious state, the client brings those kind of coping mechanisms or those forms of defense mechanisms in place so that they can manage their level of anxiety. So it is a coping mechanism used in an effort to protect the individual from feeling of anxiety. As anxiety increases and becomes overwhelming, the individuals copes by using what we call defense mechanism. So they use it to protect their ego and also decreases what we call anxiety. So that is where, if let's say, there is a situation where the client cannot handle, and the client has to employ certain defense mechanism in place in order to cope with that situation they find themselves in. Coping mechanisms and defense mechanisms are used by clients as protection from unmanageable stress and then decrease anxiety. So let's go into them one after the other, and then we look at example to them. Now, the first one we talk about is compensation. So we look at what compensation is and we look at an example with regards to compensation. Now, so compensation is putting forth extra efforts to counterbalance perceived deficiencies by emphasizing strengths. So the clients put on extra efforts to counterbalance perceived deficiencies by emphasizing strengths. So let's say, example, it says that, so let's go to the example and we'll look at that to explain it. So a business person perceives self with a small physical stature negatively and tries to overcome this by being aggressive, forceful, and then controlling in business dealing. Now, so this is what compensation is. So let's say that, you are, let's use the example, let's say a business person, the person has a very smallish stature. And you know that generally we think like people who have smallish stature, they are very weak and those kind of things. As a form of a compensation, the person will now try to be very aggressive so that people will now take the person for serious. And then people will know that, okay, the guy is very aggressive. So the person uses the aggressiveness to compensate for the fact that, he has that, smallish stature that people might override on his smallish body. So he uses aggressiveness to counteract the fact that he has a small body. Okay. And so that is what compensation means.
Hello.
Yes. Hello.
Oh, please, what's the difference between compensation and reaction formation?
I have now started.
Okay.
Why? I'm just talking about compensation. So I've just started. When we get to compensate, reaction formation, you know what reaction formation is also about. So let's go through them when we are done. Okay. Now, some of them may have, like similarities in terms of the explanation and those things, but sometimes there are clear differences between them. So I was on compensation. I said that the person tries to put extra effort in certain areas to, make up for the deficiencies that they have in other areas. And so using the example of someone who runs a business and the person has a small physical stature, people might use that smallish body, stature the person has to probably, if they buy things, they might not want to pay and those kind of things. Okay, they will override on him based on his, small body. But the person also employs the idea of, let me be aggressive on people so that they will now take me for serious and then will not use my small body stature to, override me. Okay, so that is what compensation is, putting forth extra efforts to counterbalance perceived deficiencies by emphasizing strengths. The example is what I gave. So then we have conversion. So the conversion is the expression of emotional conflict through physical symptoms that have no organic cause. So expression of emotional conflict through physical symptoms that have no organic cause. Let's look at an example. the person develops chronic abdominal pain after an emotionally traumatic event. There was no identified cause found for the symptoms. So let's say that the person has had, let's say, there's maybe broken heart. Let me use broken heart for an example. And then the person, because of that emotional trauma the person is in, I believe that any person who has experienced it, try and understand what I'm talking about. And the person now, complains of chronic abdominal pains, okay, after having that emotional issues, or after the, heartbreak. Even though you go and assess the client and then you will not find any issue like any physiological cause for the abdominal pain the client is complaining of. As a client complains of abdominal pains, even though there is no identifiable cause of the abdominal pain, but the client only complains of the abdominal pains after the emotional events, or the traumatic emotional events the client went into it. Okay, so that is what conversion is: the expression of emotional conflict through physical symptoms. After what we call broken hearts, you start complaining of chronic abdominal pains, and then we cannot associate the abdominal pains with any organic cause, as to whether it is you have ulcer or you have any abdominal issue that is causing the chronic pain. That issue cannot be identified. Okay, so that is what conversion is about. Then when it comes to denial, we all know denial, that ignoring the existence of, who's writing on my screen? Madam, you are writing on my screen. Denial is ignoring the existence of unpleasant or intolerable thoughts, feelings, needs, or impulses. Okay, so example is a 42-year-old client has just been told that the breast biopsy indicates a malignancy. When the spouse visits that evening, the client tells the spouse that the physician has not yet discussed the laboratory result. So that is what denial is about. Okay, we all know denial, that you are trying to avoid the thing, even though the thing is actually true, or the thing is actually true, but you are trying to avoid talking about it. So you have gone to the hospital, a test has been done, they say that you have malaria, but because you don't want to talk about the malaria, or because you don't want to talk about the condition. Okay, so in this instance, when you take about breast cancer, we all know how breast cancer is. Okay, very unpleasant if someone is affected with it. And so the person doesn't want to be talking about what we call the breast cancer that has been diagnosed after the biopsy. And so the client avoid talking about the situation or what the problem is about. Okay, and so that is what denial is: employing the existence of unpleasant or intolerable thoughts, feelings, needs, or impulses. Okay, something is true, but you say that it is not there, or you don't want to talk about that issue because because of how unpleasant the issue is to you. So your mother has died. They've come to tell you that your mother is no more, and then because you are using denial, you don't want to even talk about the fact that your mother is no more. Okay. So that is what denial is about. Then displacement. Okay, displacement. So displacement is where feelings about a person, object, or situations are directed to another person.
Boss.
Less threatening.
Boss Amigo.
Yes.
Can you please go back just 1 second, please? Yeah, thank you.
Let me clean the one who is writing on my screen. Now let's go on. So when you take displacement of feelings about the person, object, or situations are directed to another less threatening person, object, or situation. So this one, I will all do it. Okay, you go to work, you come, someone annoys you, you have some teddy bear in your room and you take it to throw it somewhere. Okay, so that is displacement. Okay, so let's look at the example here. A 4-year-old child is angry because of being punished by a parent for drawing on the bedroom walls. The child begins to throw war with soldier toys and has them fight each other. Okay, so when you take this example, it's very clear. The child has been punished by the parents, okay, and then for writing on the walls, okay, then the child goes into, the room, go pick his toy and start throwing the toys away, okay, or you go to work, someone's annoying you, whatever the problems is, you come and then you now kind of try to have issue with either your child or your wife or whoever, your spouse, okay, that's what we call displacement. So transferring, feelings to another person, okay, so feeling about the person, objects, or situations are directed to another less threatening person, object, or situation, okay. So you realize that you don't have any issue with your wife, okay. So there is no any issue with your wife, but you had issue with someone at work when you could not respond to the person for whatever reason it is. So when you now go home, the anger that was on you, you came to pour it onto either your wife or your children, okay, or your spouse, whatever it is. Or an object that is in the house, you come and then you start kicking it, okay. So that is what we talk about displacement, okay. Then we also have dissociation, the blocking of anxiety provoking events or period of time from the consciousness, memory, or perception to compartmentalize, what was the name? To compartmentalize, I'm not getting the word. Let me break it down.
Compartmentalize.
Compartmentalize. All right.
Compartmentalize. Compartmentalize.
Compartmentalize. Very good.
English is not English.
To compartmentalize uncomfortable, unpleasant aspects of oneself. So let's look at the example, because the example helps to explain the thing better. A person is brought to the emergency room by the police and is unable to explain who they are and where they live or work. So the blocking of an anxiety-provoking event or period of time from the consciousness memory. So you don't want to give yourself out to them. Okay. So a person is brought to the emergency room by the police and is unable to explain who they are and where they live or work. So after you have been brought in, after the person has been brought in, you ask the person for information, trying to establish who the person is and where they live and all those things. And the person is not able to provide those kind of information to you. In terms of defense mechanism, the person is, employing what we call dissociation. Then identification is the conscious or unconscious attempt to change oneself to resemble an admired person. Yes. So for this one, they say that like an adolescent trying to dress, in a way that is similar to persons that they admire. Okay. So example here is that a 15-year-old adolescent get a hairstyle like that of a young English teacher whom the adolescent admires. Okay. So, just like we the guys who like football, footballers, you see a certain footballer, done the hair or cut the hair in a certain way. And then you also want to do the same thing, like how you admire that footballer, the way the footballer dresses, the way the person I mean, the way the person cuts the hair and all that, okay? Or maybe you have someone that you admire and you want to look the same way as the way the person dresses or the way the person behaves. So that is what identification is. The conscious or unconscious attempt to change yourself to resemble someone that you admire. That is on identification. Then we talk about the next thing will be intellectualization. So intellectualization is excessive reasoning of an event based solely on facts without involving feelings or emotions. The thinking is disconnected from feelings and situations are dealt with at a cognitive level. So this one here, a person avoids dealing with anxiety in shopping malls by explaining that shopping is a frivolous waste of time and then money. And so the person tried to, use what we call, his or her intellect, okay, to avoid certain situations. And so in dealing with anxiety, the person tries to avoid going to what we call the shopping mall to shop with the mindset that when you go to the shopping mall, you are going to waste money. Okay. Ideally, we all know that yes, sometimes you go to the shopping mall and then you buy things you don't even need, and then you are wasting time and money. Okay. And the person does that to avoid, certain situations or certain, anxiety situations they find themselves in. So that is intellectualization, excessive reasoning of an event based solely on facts without involving feelings or emotion. And the thinking is disconnected from feelings, and then the situations are dealt with at a cognitive level. So we all know it is factual that sometimes, shopping could waste your time, could also waste your money. Okay. And so the person tried to use the fact that shopping in a shopping mall could waste money and time, okay, to just control the level of anxiety within the person. So if a person avoids dealing with anxiety in shopping malls by explaining that shopping is a frivolous waste of time and then money. Then we have introjection, a type of identification in which individuals incorporate the traits or values of another person into themselves. So just like we talk about identification, that you dress to resemble the person you admire, this time around, you are now inculcating the behaviors of that individual in yourself. So the person behaves this way, so you also try to behave exactly the same way the person behaves. Identification was more on dressing to look like the person, but this time around, you are now behaving the same way as how the person was behaving. So an 8-year-old example is an 8-year-old child tells a 3-year-old sibling, don't scribble in your book of nursery rhymes. Just look at the pretty pictures that's expressing the patterns, the parents' values. So you know that, like, your parents will tell you that, okay, don't write on your walls, or don't be writing on, bedroom walls, or don't be writing on the walls, and then don't be writing in your books. Now the parent is not there, so the 8-year-old is now inculcating the behaviors of the parent by telling the 3-year-old not to write anyhow in his or her nursery book, so that the 3-year-old will not kind of spoil the book. Okay, so now the 8-year-old is now behaving like the parents. Okay, so that is what introjection is. A type of identification in which an individual inculcates the traits or values of another person into themselves. So the 8-year-old is now behaving as the parent. Okay, well, he knows that the parents will always tell them not to write anyhow in their books and then on the walls. Okay, so they're exactly the same thing. He or she is also now telling the 3-year-old person or child or sibling not to also write in his or her books. Yes, and Equia.
Please, I want to know if it's like imitating.
If it's
It's like imitating, like the 3 year,
yes,
the
it's like imitation. Yes. It's like you are imitating, but this time it's more of behavioral way. Okay. Like the behaviors or the traits and values of the person is what you are now, trying to also use in this instant. So it's like imitation. Yes, you are imitating how, but in imitation, sometimes imitations would be more like walking and talking and those kind of things. So this time around, you are now adapting like good values, let me say it that way, okay, or like traits, certain traits of the person that you want to emulate. Okay. Then we have isolation. So isolation is response in which a person blocks feelings associated with an unpleasant experience. So example is that the medical student dissects a cadaver for an anatomy course without being disturbed by the thoughts of death. Okay, so you block, a feeling associated with an unpleasant thought. And in this case, you know that when you are going to, as a medical student, when you are going to work on what we call an experiment, or you are going to perform an experiment on an animal, you need to first of all kill the animal, okay, before you can now perform what we call the procedure on the animal. Now, in doing so, you also know that you need to kill it, so there is death. So you block what we call the feeling or the unpleasant experience with regards to what we call the death. Okay, and then you go ahead to kill the animal and use it for your project. So the student dissects what we call it, the animal for an anatomy course without being disturbed by the thought of so you block the fear of thoughts within you, the fear of death within you, and then you go ahead with whatever procedure you have to do. And so let's say you have certain fear within you and you want to do something. So you have to block that fear before you can now go ahead to do whatever activity you have to do. If you allow the fear to take you, you cannot go ahead to do the project. And so the same way, if the student allow the fear of death to overtake him, he cannot go ahead to use the cadaver for what we call the anatomy project he's doing. So he has to first of all block the thought of what we call the fear of death. Of course, we all fear that everybody fears to die. So you need to block that what we call fear about death. Then you now kill the animal and then you go ahead to use it for your project. There was another hand up. So the person is the hand still up or the person has struggled? Yes. Go ahead.
Okay. So I want to find out these defense mechanisms. Are they a good thing or a bad thing?
Oh, they are good things to help you.
They are good things.
Yes, they are good things to manage your situations in which you find yourself in. And unpleasant, mostly it comes into play when you are in an anxious state or in an unpleasant situations. That's when you employ them to deal with the situation.
So are there instances whereby they can be overuse of the defense mechanism that can make it bad?
Oh yes, there are instances where someone can overuse the defense mechanism. Yes, that is true. Yes, that is there.
Okay, thank you.
You're welcome. Yeah, someone, Emmanuel. Yes, Emmanuel, you can unmute yourself and come in.
Sorry, these defense mechanisms, when they are excessively used, they become a problem to the user.
Okay.
But the minimal use of them. It is everyday life situation.
Life situation.
Yeah. But the excessive use is where the problem lies with respect to mental health.
Mental health. So when the person uses it like excessively, it now becomes a problem, right?
Yes, it becomes a problem that the person needs a medical assistance.
Assistance, exactly. All right.
Okay.
Thank you. All right. Thank you for your inputs. Mr. Kabiru, I saw your hand up.
I think most of these defense mechanisms explain. Most are really giving me the understanding as to how they really minimize anxiety. But then a few of them, like this identification, introjection, I can't really relate how identification, that this in the dressing code, and then the introjection. Which one that you explain the small boy instructing this the genius
that is projection, yeah.
And those one I don't really see the connection how those things are minimizing anxiety. Well, we know that anxiety increases. Yeah. So
Yes.
I don't know.
Yes, I think I'm getting your point. So you don't know, like you're trying to understand. I mean, like the child the form of anxiety that is there that the person is using the introjection on. Is that not what you are trying to say?
Yes, to minimize.
Okay, so when it comes to anxiety and those kind of things, now let's say the book, okay, the child writes in it and then the book gets spots, okay. There's going to be, maybe the parents will even come and then try wanting to be the person up. So there's going to be some form of fear and those kind of things. It is always, just like Mr. Emmanuel said, things that are used on daily basis. Okay. So sometimes it's not just like the fear is there or the anxiety is there and the person is using it. It's not all the time that, I mean, there's going to be some form of anxiety and then you realize that the person is employing those kind of things. But this thing, sometimes you even use them unknowingly. You wouldn't even think like, this is, I mean, a defense mechanism this person is employing. But in actual sense, you go into them and you realize that, okay, this is, I mean, a defense mechanism that the person was employing. Okay. So it's not all the time that you realize, I mean, it will be clear evident that, I mean, the person has gone into some form of, I mean, anxious state or some form of anxiety. And the person is expressing, I mean, those kind of defense mechanism. You can use it unknowingly, and it is defense mechanism you are employing. Now, let's look at projection. So projection is transferring one's internal feelings, thoughts, or unacceptable ideas and traits to someone. So example is a young person who denies sexual feelings about a co-worker, accuses the co-worker of attempting to seduce, attempting seductive behavior without any basis for it. So this is like you wanting the person, okay, and you are now turning around to say that there's a person who is trying to seduce, I mean, you to like her. Okay, so that is projection, transferring one's internal feelings, thoughts, or unacceptable ideas and traits to someone else. So I mean, a young person who denies sexual feelings about a co-worker. So within you, you know that you like the person. Okay, you have that kind of feeling for the person, but you try to avoid that by saying that it is that person who always, I mean, seduces you, or who always dresses in such a way that, I mean, it will draw your attention to the person. Okay, so that is on projection. Then rationalization, an attempt to make unacceptable feelings and behaviors acceptable by justifying the behavior. Now let's look at the example. Now, a student fails an exam and complains that the lectures were not well organized or clearly presented. So just like, I mean, let's use this example that what we are doing here. Someone goes to write the exam and then comes and is not able to make it. And the person now comes to put the blame on us that, oh, you people did not teach us well. You people did not, I mean, your classes were not well organized. And so the person is now blaming us for, I mean, the failure, okay? Or, I mean, in our schools, you write exam, you fail, and now you now blame what we call your failure on what we call your lecturer, with the fact that your lecturer did not organize the lectures, and then, I mean, your assignment, everything wasn't organized well. And so you are now blaming your tutor or your lecturer for your failure. So an attempt to make an unacceptable feelings and behavior acceptable by justifying the behavior. That is unrationalization. Now, the reaction formation, someone was asking it. So here is reaction formation. It says that developing conscious attempts and behaviors and acting out behaviors opposite to what one really feels. Example, a married person who feels attracted to one of a spouse friend's traits. Sorry, I mean, one of a spouse's friends treats I want to get it. A married person who feels attracted to one of a spouse friends treats the friend rudely. So this is how it goes. You like your spouse friend, okay, you are attracted to that colleague or that friend of your spouse, and now you try to treat the person badly, okay, even though you like the person. So let's say that your wife friend or your husband's friend, you are attracted to the person or you like the person, but you find a way to treat the person badly, even though deep within you, you like the person. That is what reaction formation is. So developing conscious attempts and behaviors and acting out behaviors opposite to what one really feels. So I like you, or let's say that I like you, and then I try to act opposite to the feeling that deep within me I have for you. Okay, so I like you, but anytime I see you, I act rudely towards you. I hope you get it. So that is what reaction formation. I think the person was asking the difference between reaction formation and then was it compensation. So we said compensation is where the person tries to use a different thing to counteract their weakness. So you are running a business, you have a short stature, and then you now have to develop certain traits, like you have to be aggressive before people will take you for serious. Okay, that is on compensation. But reaction formation is that you are acting opposite to what you actually feel. So I like you, but anytime I see you, I try to act rudely towards you. However, deep within me, I like you. So that is what reaction formation means. Then I think the last but not the least is regression. That's returning to an earlier behavior that you have already passed there. Okay, so returning to an earlier developmental stage and pattern of behavior to express an impulse deal with anxiety. Okay, so let's look at the example here. A 4-year-old child, let me land before you come in and carry me. A 4-year-old child who has been toilet trained for more than 1 year begins to, wet pants again when a new baby is brought home from the hospital. So that is regression, going back to, something that under normal circumstance you shouldn't have been doing. So when it takes developmental stages, we know that by 4 years, the person might have been toilet trained. And so instances of bedwetting is no more an issue. But the person now goes back to what we call bedwetting, when the child goes into any form of anxious state, or when there's any form of anxiety, then the child starts to bedwet him or herself. So in this instance, it says that the 4-year-old child has been toilet trained for 1 year, means that for almost 1 year, the child is not, bedwetting. But the moment they brought in a new baby to the house, or the mother had given birth and then there's a new baby in the house, the child is now bedwetting. Okay, so that is what we call regression, going back to certain developmental stage that you have already passed and you are now doing that. Okay, so to make it up for the anxiety or the anxious state you find yourself in. So that is on what we call regression. So we all understand regression, going back to something you have already passed. Yes, the one whose hand was out, carry on.
So please, I want to find out with the regression that it only happens like in children for
children.
For instance, the example that you gave. Aren't there instances it can happen in like adults?
Adults. Oh yeah, it does happen. It can happen in adults. Okay.
So can you please give me an example so that I understand?
Can I come in?
Yes, someone wants to come in.
Yeah, it's like, especially, let's assume females, okay? Sometimes when something happens to you or unpleasant thing happens to you, you become to act like a baby, or someone putting like his finger in the mouth to assume like a baby, okay? So it's opposite of progression. Progress means you are going forward. Regress, going back, okay? So when you are behaving backwards, or the attitude or behavior represents something that has like your early developmental stages, okay? So like as I said, the female women, they begin to cry during, let's say, something that is not even relevant for them to cry. Then they begin to cry to act as if they are a baby. Okay.
Like the men also sucking women breast.
No, that one they know.
Because men they know.
Thank you.
All right, thank you, Sir Frank. There's 2 hands up, Rashida.
Okay, can this also be associated, like, can this also be an example when, let's say, you have an issue with someone and let's say you have forgiven, we are talking about this thing, we have all forgiven each other, we have moved on 1-2 months, then you remember everything and you start showing all the emotions again. Does that also apply?
No, it wouldn't be
yeah, that's not regression.
No, that is not it. So
what would that be?
It's more of regression is more of like you returning to an earlier developmental stage. So unless you are acting like something you should not be doing. Okay. So in your situation where you are now acting, what would it be that you have now remembered the thing and you are now like behaving abnormally? Is that not what you are asking? Like after some months of which you have sorted the issue out and you remember what happened between you and the person and you start acting out, in an unpleasant way, unless you are doing something that is related with some developmental stage. That is when we can only say that it is regression. Okay, let me see. There is another hand up. Let me listen to Mr. Emmanuel. Probably Mr. Emmanuel has a better way to help us out.
All right, sir, thank you. This one, the most appropriate example in the clinical practice is throwing of temper tantrums.
Okay.
Mostly we know that it is children and young infants and children that through temper tantrums. And it is acceptable at their stage. But when an adult in a situation, maybe a spouse misconduct himself or herself, and then the other person started behaving as if he's a child, and they go lower than the behavior at that stage. That stage is what, yes, that's what we are describing as being
regression.
Yes, yes. Thank you so much.
All right, thank you. So so in this, Rashida, in your case, it will be very difficult to determine, I mean, if it's not based on, I mean, developmental stage that when you remember the situation, you are now acting that way. We cannot say it is, I mean, regression. Based on what we have discussed with regards to the various,
okay, I understand now. This one, it has to be a developmental stage that has been passed and has been returned to. Okay.
It has been returned to.
Yeah.
I hope you get it.
Okay, so Sir Mingo.
Hello, madam.
Then I want to believe that this thing it's an unconscious something. It's associated with with the unconscious mind, on the unconscious state. You don't deliberately do it.
Some of them you deliberately do. So now you're talking about, regression, right?
Yes, please. Yes, please.
Okay. But it can also be, a conscious effort too, that you want to, because of the situation you find yourself in, you try to act like a child, or you try to, act like the way something that, see, when we take even the bedwetting aspect as, part thing, you can know that at this point I need to go and then free myself, but because of that situation you find yourself in, okay, you bedwet yourself to try to catch some form of attention. Okay, so the mothers here, I believe you what I'm talking about, you know it. You have a child, maybe the child has done something or is doing something, you want to ignore what the person is doing. Then the child will now do something that, and I know what's the child shouldn't do. Okay, just to catch your attention so that you can now attend to the child. So it can be conscious, it can also be unconscious. Okay. So for regression, it can be conscious, it can also be unconscious. Yes.
So Amingo.
Yes.
Can you associate hysteria in the way to it?
No. Hysteria is just like you are like, let's say there's pain and you are expressing the pain too much. Is that not the case? Is that not the case? So that is not, regression. Regression is that you are going back to something that you have already passed. Okay. But hysteria, yes, you have, the problem is there, but the person does the thing in essence. The person, like, how should I? Oh, yeah, no. That's what I want to say. So, Madam Kara, I don't know whether you get it.
Please, can I come in?
Okay.
Please. So for the regression is related to stages of behavior.
Yes.
So let's say behavior change. Somebody was an addict and then had gone through certain stages of trying to be free from the addiction. And now the person maybe is sober. Let's say the person was an alcoholic and has been sober for about 3 months.
Yeah.
Then maybe an unfortunate event happens and the person goes back to drinking. Can that one be called regression?
Yeah, I think it can also be said to be regression.
Okay.
Yeah.
Thank you.
Let's talk about the last thing, repression. So,
hello.
Yes.
If what's my the earliest the one who just spoke, if example is part of regression. Then that one, there is no developmental issue in it.
Yes, so there's no developmental issue with it, but so we are using that in the sense that the person is going back to something that a person has already dealt with, and the person has transitioned from that situation. The person is now good. So this one is more like a behavioral thing. Okay, so
Regression is not only associated with the relapse. What is relapse?
okay, so that will be relapse. All right.
Yes.
Okay. Mr. Emmanuel, you wanted to come in again. Which one I'll call you? Let's listen to Mr. Emmanuel.
Yes, one brother has already brought the word. The word is relapse. In that
Relapse.
case,
Okay.
yes, the person had a medical problem. The problem has been resolved, and the person
That is relapse.
Went back to the old behavior, the disease state. But in the case of the regression, this one is mainly
developmental stage.
Developmental stage behavior.
Okay.
Matured.
All right.
But he's putting up that behavior lower the lower ages of development. That's why they are calling it regression.
Okay. So let's get it once and for all that regression is about developmental issues. Okay.
Yeah.
All right.
Amigo.
Yes, hello.
Regression is one of the primitive defense mechanisms.
Okay.
We have the matured one and then the primitive one. The primitive one is that of the developmental stage, temper tantrum, and those things. But once we have matured and we are putting up a behavior lower at the developmental ages of life, then we are having a problem called the regression.
Okay.
Yeah. Thank you so much.
Thank you too. Thank you. There was a hand up. Mr. Richmond, you drop your hand again. If you are with us, you can come in before Nancy will come. Mr. Richmond, we cannot hear you. I see that you have unmuted. Okay. Nancy, let's go. I'm sure he will position himself well and come back.
Okay, so can we use this as an example? A lady gets a broken heart and then she gets home and she cries so much and takes her teddy bear, hugs the teddy bear, cries so much to the teddy bear. Is this an example of regression?
I gave an example of that. That is let me come here. Over here. Displacement. That is displacement. Okay, Nancy. Hello, Nancy.
Okay.
That is displacement. Okay. So the unpleasant situation here was the fact that you had broken heart. Okay, you could not talk to your fiancé or whoever the person. Or you go home and you now pick your teddy bear and you start throwing the teddy bear away and those kind of things. That is displacement. Okay. Yes, there was another person who wanted to come in. Okay, last one. Yes, Narabek, you can come in.
Yes, I wanted to bring in another example if it will help clarify the situation, like what we see on social media nowadays. Like people go through divorce and then they go back and start behaving like adolescents, trying to look good, trying to like appear like just as adolescents do. I don't know if that helps. Like making a whole lot of videos each and every day, saying things and behaving like adolescents. I don't know if that helps. Thank you.
It will still not be on. It will still not be regression. Okay. What you are saying is that, I mean, the person is now dressing in a certain way to kind of, I mean,
To prove a point,
suppress
to look
what,
like an adolescent.
just to
Yeah,
look like what,
suppress the ability.
to look like
An adolescent.
an
Like
adolescent.
behaving just as adolescents behave, like things we did when we're adolescents.
Okay.
Yeah.
So this time I said the person is dressing to look like an adolescent.
Dressing and behaving, maybe, yeah, being flirtatious and like trying to attract attention and all these things. You know, adolescents spend a lot of time on themselves, trying to look good, to be acceptable, and
Yes, I get the point. I get it very well. I get your point very well. Yes. Can it be considered, Mr. Ibarra, can it be considered as a regression? Yes, I think so far as a person is now behaving like an adolescent, okay, how an adolescent will behave. Yes, in that instant, it can be considered as a regression because at that point, you might have passed that stage of how an adolescent will behave. So if you are now behaving like an adolescent after that broken heart issues or whatever situation you went into, that means that you have regressed back to that, developmental stage. So you can consider that form as a regression. Hey, and then yeah, almost anymore. Abi winning. Sorry.
Sir, please, I answered one question. I wanted to bring it here if it could help. I think
Okay.
the question was about someone working in an office. Then something happened. So when the colleagues left, the person scattered all the papers from the table, and they were asking which one. I got it wrong. I chose displacement. I got it wrong. So they told me it was rather a regression.
Okay.
Me, I chose displacement. So I had it wrong. It was regression.
Yeah, so in that instance, and in normal circumstance, the person will not really be acting out that way. I mean, like a child. Okay.
Yes.
This time around, the person is now scattering the things in the room and everything, like how a child would behave. Okay.
Yeah.
Okay. All right. So I think it makes sense as well. Yeah. Karim, your hand is still up. We'll take the last one from Karim, then we make progress. I'll talk about
What I want to say is that for the definition we have here, it says earlier developmental stage. And please, can you hear me?
Yeah, I think it's now clear.
Hello.
Yeah,
Okay.
kindly go ahead.
So for the regression, the definition, the explanation there is earlier developmental stage and then pattern of behavior.
Yeah.
You understand? So if we are talking about developmental stage, then the pattern of behavior too should be considered. So it's not only you behaving like a child that makes it regression. Any other pattern of behavior, if maybe just like somebody gave an example that somebody behaving like an adolescent, we or she know that he or she is not an adolescent. But if you start behaving like an adolescent whilst you're an adult as a reaction to you being anxious about something or something that has happened to you, we can consider that one too as regression.
Yes, I think I did say that. Yeah, that can be considered. Yes.
Okay, then I didn't hear my network was worrying me.
Yes, I said that considered. Yes, can be considered.
Okay, thank you. Because I'm saying this because of what the example I gave and somebody said is rather relapse.
Yes, so your own is more of so your own, that is the most appropriate term to give it because it was
are
like
you sure? Because it's a behavioral change, right?
Yes, but
addiction, trying to
nobody,
overcome addiction.
Let me come.
Okay.
You see the adolescent thing, every person pass through that stage.
Yes.
But drinking alcohol is not everybody who drinks alcohol.
Okay.
So are you getting the point I'm making? For regression to happen, you should pass through that stage, that behavior, or you should have passed through that.
But what I'm also trying to say is behavior change comes in stages.
Yes,
right.
I get your point.
So at a certain point, the person has passed a stage whereby he or she is able to break free of that unacceptable behavior.
the alcohol
or it
aspect,
still doesn't apply?
the alcohol aspect, it makes it to become more of like a condition the person was having. But with regression, it's not a condition, like it's not like a medical condition, or I don't know whether the point I'm making, you are getting me.
Okay.
So
I'm not getting it, but you are going to read more about it so that I'll
no,
get it. So I don't want to drag the
yeah,
class.
the alcohol aspect, it is not everybody who drinks
Let's
alcohol.
Oh, yes,
Kindly
I
mute
get
that.
it. I get it. But what I'm trying to say is it's a
Oh,
behavioral change. And
No,
here
that
we are
those
talking about both developmental and behavioral pattern. So if you are talking about behavioral pattern, that means at a certain point, that person had passed a certain pattern of behavior.
it wasn't normal for the person to pass through that. It is because of the alcohol the person was taking. That was why the person was behaving that way. Are you getting me? With the regression, it is the normal phenomenon that everybody will
Let's
pass through
continue.
that. No. I just want you to understand that. With
No,
the
it's okay. Let's continue. I
okay.
understand what you are saying now. I understand. Okay. Thank you.
All right. The next, yeah, you have something
So
again.
no, I've seen one example here, and I just want to read it out.
Okay, it's under what?
The regression.
Okay, go ahead.
Because a patient newly diagnosed with cancer tells into a fetal position and cries.
A patient newly diagnosed with cancer.
Yes, tells into a fetal position and cries.
Okay. So we know that under normal circumstance, I mean, or the fetal position is something that happens, I mean, during infancy. Is that not the case? And every child will assume that position in one way or the other, especially when they are crying and those things. So when the person was told that she's having the cancer, then the person now had to assume that, I mean, fetal position and then now crying. So that makes it to become the regression. So the person has gone back to an earlier developmental stage in terms of positioning. Okay, we know that adults, unless you are afflicted with something before you start, I mean, position like assuming a fetal position. All right, let's do the last one. That is repression, an unconscious process in which the client blocks undesirable and then undesirable and unacceptable thoughts or ideas from conscious expressions. Example, kindly Yvette, let me mute her out.
Oh,
Sorry. So example is a person does not recall hitting the spouse when told about the spouse's pregnancy. So you have done something that is unflexible, okay. And then you are told about something and then you now behave as if you didn't do that. So an unconscious process in which the client blocks undesirable and unacceptable thoughts or ideas from conscious expression. So the moment you were told that the person is pregnant, you are not saying that, I mean, you didn't hit the person. So a person does not recall hitting the spouse when told about the spouse's pregnancy. That is repression. And we bring that, or that would be the last thing with regards to what we call defense mechanism, the various examples or types and the examples with them. I think we have dealt with them extensively. We get questions. Some of these things is the questions that will help us to get a better understanding. So when you get the questions and the questions now are framed, you try to relate it together and see how you get a better understanding of it. This will be the last thing and then we'll drop that here for today, where the types of discharge is voluntary and involuntary admission specifically. I mean, in what situations do we use voluntary admissions? In what situations, I mean, involuntary admissions will be asked on the client, and what are some of the things you need to do when someone is admitted involuntarily? I mean, do you need an order from court? Do you need an order from a psychiatrist before you admit someone involuntarily, and all those things? So I'll just go through it briefly in about 5 or 10 minutes, and then we'll drop it there. So with voluntary admission, the client or the client's guardian seeks admission for the client. So we know that with voluntary admissions, like the name goes, I brought myself that take care of me. So I can ask for discharge at any point in time when it comes to voluntary admission. So voluntary, I go, or the client goes, him or herself, or the guardian or whoever is legally responsible to take care of the person sends the client in, and then the client is taken care of. And the guardian or the client can ask that they should be discharged. Okay, we looked at involuntary as to whether a client can ask for, discharge by themselves as well. So the voluntary client is free to sign out of the hospital with, the psychiatrist or the primary healthcare provider's notification and prescription. So for these people, when they come to you that I want to go home, you have no right to say that you won't discharge them. You only, have to let a healthcare provider sign it that, okay, client says I want to go home. So you have to allow the client to go, discharge the client to go home. We don't keep them. If you keep them, the client can see you for what we call assault, can see you for any form of, forced imprisonment. Yes. So you have to forced imprisonment. So you have to be very careful with that. Okay, you meet questions on that. That clients admitted voluntarily ask you of ask that they want to be discharged from. You say no. What kind of legal issue can you be sued of? So you should be mindful of that. That you can meet those kind of questions. Then detaining voluntary clients against their will is termed as false imprisonment. Then the client also retains full civil rights. So patient care partnership, and then in terms of confidentiality, everything, you need to respect all the rights when it comes to confidentiality, who you have to release client information to and who you are not supposed to release the client information to. If client hasn't given you hasn't cleared that release my information to someone, you are not supposed to give the information out to this person. So the client has the legal right to agree or disagree in terms of treatment and care. Then when it comes to the involuntary, admissions may be necessary when a person is mentally ill, is a danger to self or others, and then there is a need for mental health treatment or physical care. So we have to understand that involuntary admission can be made without a physician's order, or the psychiatrist's order or a court order. Okay, especially when you notice that the person is becoming a threat to other people. In that instant, the person can be admitted without an order from courts or without a person's will. So in that instant, the client can be picked and then sent to the hospital for admission. Okay. Involuntary admissions occurs when a person is admitted or detained involuntarily for mental health treatment because of actual or imminent danger to self or others. The person's condition is deteriorating and they require hospitalization. So just like I said, the person is becoming threat to others and then himself or herself. In that instant, the clients can be picked and then sent to the hospital for admission without the client's consent. Clients who are admitted involuntarily, they also retain the rights to inform consent as well. Then the client also retain the right to refuse treatments, including medications, unless a separate or a specific treatment order is obtained from the court. So the client has the right to refuse any treatment unless there is a court order that whether the client like it or not, do this for the client. For that one, you have to go according to the court order for involuntary admissions. If there is no any kind of, specific treatment order from the court, then a client who is admitted involuntarily has the right to accept or decline any form of treatment. The client also loses the right to refuse treatment when they poses an immediate threat to self or others. So you see where the issues are coming in. So we are saying that someone who is admitted to the hospital involuntarily has a right to decline. However, there is an exception here. If the client is now at the risk or is posing danger, immediate danger to others, then the client cannot say that I don't like this treatment, I don't like this. For that one, the client cannot refuse. Okay, or client cannot decline. Unless the client is not in danger and then was admitted involuntarily. For that instant, the client can refuse. But if the client is in danger to self and others, in that instant, whatever treatment is there, you need to administer it or you need to give it to the client, whether the clients like it or not. Then, depending on the jurisdiction as well, an order from an external body, such as a court or from a psychiatrist or the primary healthcare provider, is also required for involuntary admission, except in the case of emergency. So most of the time, like I said, you will need a court order for an involuntary admission, except in the case where the person is a threat to, or is a threat to others and then himself, or there's an immediate danger or there's an emergency. For that one, you can admit the client involuntarily without the court order. You have to make sure that which allows the time to obtain necessary orders from. So if it is an emergency situation, the client was brought in, you have to make sure that you have to get all the orders from courts and the psychiatrists and everything you need. So that has to be done within 72-hour period, okay, for further evaluation. So let's say someone has been brought in involuntarily, the person was in emergency situation or was in danger to other people, and you have admitted the person, you still need a court order for that form of admission, or you need a psychiatrist to come in for that. And there is a time duration that you need to do that. That's within 72 hours that you need to obtain all the necessary legal the legal counsels or the court orders. So you have that within that 72 hours to prepare for all those documentation that the person has been admitted involuntarily based on the fact that the person was in danger to self and others. Then for this one, it's more of court issues and those kind of things that, in the States, an external hearing is held by an external board within which a specified time period where a client admitted involuntarily. The specific time period varies by state. Psychiatrist or the primary healthcare provider may also be the person making decisions surrounding the client discuss depending on the location. So like I said, there is a time frame within which if someone is admitted involuntarily without a court order or like an initial court order or an initial psychiatrist order, then you need to make sure that you have to work around it so that you get all the necessary legal backing for admitting the client involuntarily. The clients can also institute a hearing themselves, okay, so that they can be discharged home. And then at the hearing, those things are more of court things. So at the hearing, a determination is made to whether the clients may be released from the hospital or detained for further treatment or evaluation, or committed to a mental health facility for an undetermined period. So court has to determine as to whether the client should still be on admission or the client should be discharged. So the client has the right to seek for legal help, okay, that I have been admitted involuntarily based on this and this. I need a legal assistance so that I'll be released from the hospital. And that has to go to court to determine that the client can be released. A client has a right to us the right to treatment in the least restrictive environment. So if you're admitting someone involuntarily, you need to make sure that you are not restraining the client too much. So you need to make sure the client is cared for in a least restricted treatment environment. If treatment objectives can be achieved by court-ordered treatment so what that point is trying to seek to tell us that if someone is admitted involuntarily, the court can come in and determine that, okay, this person can be treated on outpatient basis. And so allow the person to go home and then be coming for treatment on an outpatient basis. If the court deem it fit that the person can go home and be coming for that, or the psychiatrist also think that the client can be treated on outpatient basis, allow the person to be treated on an outpatient basis. A client is also considered legally competent unless the client has been declared incompetent through a legal hearing, separate from the involuntary committing hearing. So you have to have all the legal things in place to make sure that, okay, the court is saying that this person is not incompetent to make decisions before you try to seek for others to make decisions on client behalf. Other than that, the client is legally competent unless it's specified by the law court that client is not.
Power on. AUX mode.
Sorry, the clients cannot make those decisions. In the course of providing care and carrying out your medical prescription, if the nurse believes that a client lacks competency to make informed decisions, action should be initiated to determine whether a legal guardian or a substitute decision maker needs to be appointed by the court. So whilst you are caring for your clients, if you noted or if you notice that the client at a point, in terms of competency to make decision, it's not lacks some form of competencies, you have, that right to also inform the appropriate authority so that a legal guardian or someone will be appointed to be making decisions for the client. So that is on involuntary and voluntary admissions. We need to know the distinction between the two and then what we need for each of them when it comes to the forms of admissions that we have. So that will be the last thing for today. I think our time is far gone. We are about 16 minutes into our time. I don't know if we can take questions before we end it there, or we are tired. Which one is which? All right. So let's do one or two questions and then we see what we can do. Or if that one has a question, a person wants to ask, the person can bring it on board. All right. A patient with a diagnosis of major depression who has attempted suicide says to the nurse, "I should have died. I have always been a failure. Nothing ever goes right for me." Which response demonstrates therapeutic communication? 1. Or A, you have everything to live for. B, why do you see yourself as a failure? C, feeling like this is all part of being depressed. You have been feeling like a failure for a while. So if you want to answer, you can come in with your answers and then we'll see what's the correct answer is. Yes, Mr. Emmanuel.
I'll go for option A. You have everything to live.
Okay.
The reason being that earlier we saw in the therapeutic communication that we need give an open communication. We don't need to give false reassurances to our clients.
Okay.
Because of these two reasons, I will go for you have everything to live.
Okay. All right. Thank you, Mr. Emmanuel. Those going for D. Why going for D? Our D family and the C family. Why D? Why C? Yes, Mary. Madam Mary, can you
Hello.
continue? Yeah, Madam
Hello.
Mary.
Oh, okay.
Okay, thank you very much. I said I also go with Mr. Ima. A,
Okay.
the client is already having suicidal thoughts, so there's no need trying to ask certain things that will let the client feel more depressed. So you have everything to live for. That's what I'm going for. Maybe why do you should stop asking people why? Because
Okay.
why is not applied in mental health? Feeling like this is all part of being depressed. This one is not therapeutic. You have been feeling like a failure for a while. Somebody who is already depressed and saying that he feel like a failure, then you are not even increasing the issue. Then I will go for A.
Okay.
Thank you.
All right. Thank you. Let's take a last one. Amina.
I'll take D.
Okay.
You have everything to live for. You are not the one to tell the patient what he or she has and doesn't have. We are trying to help the patient express him or herself. So that one is out. And already we've been told that we shouldn't be asking questions starting with why. So the B2 is out. Then the C, feeling like this is all part of being depressed. We all, as a healthcare provider, you know it is a process, but this is not the time to tell the client what the process entails. You are supposed to allow the client to express him or herself. Then through that, you also know how to communicate. But with the D, if you are saying you've been feeling like a failure for a while, it's an open-ended question. The patient can now begin to tell you more. When he or she started feeling depressed, how it started, feeling like a failure, how it started, what is making him or her, her feel like a failure. So I'll go for the D.
So the D's had it then. So responding to the client feelings, responding to the feelings expressed by the client is an effective therapeutic technique. Correct option is an example of the use of restating. So this is restating. You have been feeling like a failure for a while. So you are restating what the client said for the client to give you more information on the situation. So yes, it was D. All right, let's take another one. When the community health nurse visits a patient at home, the patient states, I haven't slept the last couple of nights, which response by the nurse illustrates a therapeutic communication response to this patient. A, I see. B, really. C, you are having difficulty sleeping. D, sometimes I have trouble sleeping too. So after the first question, I believe this one is very easy for us. Right. Who is talking for us? Today is Mr. Paul with us today. I haven't heard of Mr. Paul's voice today. Mr. Paul, are you with us?
I'm around, boss.
Yeah, around.
Yeah.
All right, Mr. Paul, thank you. So for this one, it's clear, right, that C, you are restating, right? So restatement, you are restating the client's comment, whatever client said. So C is also the correct one, restatement. You are restating whatever was said, right? So that is correct for C. Let's see what we have next. Okay. This is on defense mechanism. A patient admitted to a mental health unit for treatment of psychotic behavior spends hours at the locked exit door shouting, "Let me out. There is nothing wrong with me. I don't belong here." What defense mechanism is the patient implementing? Yes, Madam Mary.
Thank you. I think I would go for A, denial. The client is trying to deny that he's not having any problem with his body. So he's in the denial stage.
Client is in the denial stage.
Yes, please. Thank you.
Madam Mary is saying that client is in the denial stage. Do you agree that it is denial? Or you think it is something else? You think it is projection? You think it is regression? You think it is, rationalization? All right. So I think we all agree that the client is refusing to accept the reality that he or she has been diagnosed with a psychotic condition. So the client is shouting that, "Let me out. I don't have what you are saying I have." So that is this question with regards to defense mechanism. Another question here. A patient diagnosed with terminal cancer says to the nurse, "I am going to die, and I wish my family would stop hoping for a cure. I get so angry when they carry on like this. After all, I am the one who is dying." Which response by the nurse is therapeutic? A, have you shared your feelings with your family? B, I think we should talk more about your anger with your family. C, you are feeling angry that your family continues to hope for you to be cured. D, you are probably very depressed, which is understandable with such a diagnosis. So which one is also the appropriate statement to make with regards to what the client is feeling? Yes, Madam Mary, you want to help us well?
Okay. With A, have you shared your feelings with your family? Is trying to ask for yes or no answer, which I don't buy into it. Then I'll go for B. I think we should talk more about your anger with your family. Then that's what I'm going for. Then the C say you are feeling angry that your family continues to hope for you to be cured. No, I'm not picking that one. You are probably very depressed, which is understandable with such a diagnosis. I'm going for the B. Thank you.
You are going for B, okay.
Yes, I think we should talk more about your anger with your family so that she will be able to express what is actually worrying her to the family so that they will all come into consensus than the others. Thank you.
All right. So those going for C, tell us why you're going for C. Sarah. Yes, Madam Sarah, you can talk.
C is restating. Yeah, so I said the restating.
He says C is restatement. Oh, the line is breaking.
The patient restating what the patient said, and so that is what I'll go for.
Okay, so you're going for C. I didn't get some part of your contribution, but I think the final thing was that you said you are going for C, which is a restatement. Clients, you are restating what the client said, okay, which is correct. So yes, the correct answer is C. Restating is a therapeutic communication, as we all know. All right, I see that some people are already leaving us, okay. And so I have a lot of questions. You know, we did a lot of things, so we should have done a lot of questions on all the things we did. So I will leave it here for today. And then we meet again, God willing, on Friday next week.
So let's do some few questions.
Next week when we meet, Madam Carol. Okay. All right. Let's respect the
Thank you
time.
very much.
All right. Sure.